I am your host, U.S. Army Flight Surgeon and Iraq Combat Veteran Medic, retired Colonel Dr. Damon Arnold. Our discussion concerns the JBVA Prostate Cancer Awareness and Caregiver Support Program. We have two distinguished panelists with us today. The first is Dr. Joel Cornfield, MD, who is the Section Chief of Urology at the Jesse Brown VA Medical Center. He completed his MD degree at the University of Wisconsin and his residency and fellowship training at the University of Illinois and then the Westside VA Hospitals, now known as Jesse Brown VA. For those who are back of our time, I remember back in the days we called it Westside VA. We also have, hello, Dr. Cornfield. And we also have Janika Walker, is a licensed clinical social worker, which is really close to my heart. My mother was a social worker for many years, from age 22 to 91. She actually, shortly before she had a major stroke, she was knocking on people's doors to make sure they took their medications 2 weeks before. But she is holds a master's degree in social work with a concentration in mental health from the University of Illinois, Champaign-Urbana. She is the manager of the Caregiver Support Program at Jesse Brown VA Medical Center. She has extensive experience with nonprofits and criminal justice advocacy aimed at caregiver, psychoeducation, homelessness outreach, supportive services, and reducing recidivism. What a distinguished career. It sounds like you're busy every second of every day with that kind of background.
Thank you.
So welcome to you both. And today we're going to be talking about prostate cancer and questions that the audience may have in their minds that you can sort of address. So the first question I have for you, and I'll go to Dr. Cornfield first. What does the prostate gland do? And what are some of the health risks associated with having a prostate?
Well, the prostate sits just beneath the bladder. And it surrounds the urethra. So at that point, anatomically, the urethra is made up of the prostate, and the prostate makes semen, not the sperm. The sperm and the semen are then stored in two little glands next to the prostate called seminal vesicle, and then there's ejaculatory ducts that course through the prostate, and when someone ejaculates, when a male ejaculates, the semen with the sperm in it is projected out.
Okay.
And so the prostate is important for reproduction.
Yeah, how big is the prostate gland about?
We always say, the size of a walnut.
A walnut,
but,
okay.
It can be 20 grams to 30 grams on an average size. When people are a little older, it starts to grow, and it can cause some problems with obstruction and infection. And it can get to be quite large. It can get up to be 10, 12 ounces even, which is obviously significant.
Yes. Yeah,
the other issue that people are concerned about with the prostate and health risks for the prostate is the development of prostate cancer,
yes,
which is what we wanted to talk about today.
Yes. And then we can go into a little bit more about that, about, the enlarged prostate versus prostate cancer and what that means. But what are some of the risk factors for developing prostate cancer? We always talk about risk factors in health.
The main risk factors are age, which is really everybody's goal, right? Family history. There can be genetic risk factors. So someone could be BRCA1 or BRCA2 positive and be prone to developing prostate cancer. And of course, at Jesse Brown, one of the big risk factors is being Black, African-American. The African-American men tend to develop prostate cancer at an earlier age. It tends to be more aggressive. And so we tend to be a little more aggressive about making the diagnosis earlier. We do start screening Black men earlier, and we are probably a little bit quicker to do biopsies.
Yes. Yeah, because actually, back in 2003, I was diagnosed with prostate cancer. So I ended up having, a prostate resection and removal. But that was 3 months before something happened. I was in my, bed at the hospital after having the surgery. And then Colin Powell came on and they asked him, well, when are you going back to work? And they said 3 months. And he said, how about 2 weeks? I'm going to go back to work. So it motivated me. And I actually went over to serve my first tour of duty in Iraq, 3 months later. And luckily I had a Vietnam surgeon and he actually did the surgery. And he and he said, and I said, you're going to sign this release to let me go, right? Because you were served too. So he finally signed it. He said, go ahead.
And obviously he was right.
Yeah, he was right. And so that was that. So I've been doing fine after that. The surgeries are much better than they used to be, years ago. With some of the complications, so you still have some risk, but not quite as much as you had some years ago. So how do you screen and check for prostate cancer?
Well, the initial screening begins with the rectal exam.
Yes.
If the rectal exam is completely normal, we'll still obtain a PSA on men as they turn African American men as they turn 45, Caucasian men as they turn 50. And we have a range of normal. It should be anywhere from 0 to 4. And interestingly, the PSA, well, everybody talks about it, is an enzyme that is required for the semen to become liquefied.
Yes.
So without the PSA and the heavy concentration of PSA, you wouldn't get the liquefaction of the semen, and you wouldn't be able to impregnate anybody.
Yes.
So we do the rectal exam and the PSA, and then over the last few years, we've started pairing the rectal exam and the PSA with an MRI of the prostate, which is closer to the tissue to tell us where there's riskier areas as opposed to more normal-looking areas. You can direct the biopsy. In general, if you have a rectal exam and we feel something hard or a nodule or some asymmetry, that in and of itself is enough to trigger a biopsy. If you have an elevated PSA, depending on how high, if it's really high, that may trigger a biopsy, even with a normal exam. If you have a PSA somewhere between 4 and 10, usually we'll get a fractionated PSA and see if the varieties of the PSA in the bloodstream are correct and adequate enough for us to put off the biopsy. If not, we'll go ahead with another biopsy. And then the biopsies we do can be done either transrectally or transperineally. Usually when we do a transperineal biopsy, we'll have the patient under an anesthesia. There's a little bit less risk of infection, a little bit less risk of bleeding with that, but the trade-off is the anesthesia. And so most people will opt for the transrectal biopsy. And sometimes you'll have conflicting data. You'll have a PSA that's quite high and an MRI that's normal, and then a biopsy that's positive, or even vice versa. And so it really requires putting all of the pieces of the puzzle together to sort of decide who gets a biopsy and who doesn't get a biopsy. And then, of course, we do offer patients the opportunity not to have their PSA done, not to have a rectal exam if they're opposed to it. And then we'll try to work around with either, let's say someone doesn't want a rectal exam, we'll try to work around that with a PSA and an MRI. Or if someone doesn't want a repeat PSA or a repeat biopsy, we'll follow them. We try to work within the framework of what the patients will allow us to do, in the sense that not everybody, you can lead a horse to water, but you can't make them drink, right? Not everybody wants to have, that kind of an invasion. And then, of course, as people turn 70, 71, 72, there's a lot of talk about being less aggressive in terms of making the diagnosis, because then you're butting up against someone's natural life expectancy. And the reality is that the treatments for prostate cancer are, for the first 10 years between radiation and surgery, the results are essentially the same. And then after about 10 years, you start to see a divergence in the results. And so people who have surgery will have better results at 15 years than people that have radiation. But if you're 75, right, you have to assess what your life expectancy is going to be and make a decision about whether you want to just be watched, or have radiation, whether you want to get community care for some kind of focal therapy, or have surgery. And we do 2 different varieties of surgery at Jesse Brown. We do open surgery and we do the robotic surgery. And the long-term results for both of those surgeries are fairly consistent across the board, with the same rates of incontinence and impotence. However, with the robotic surgery, people tend to leave the hospital sooner. They tend to recover faster. They tend to get up faster. They tend to have less blood loss, things like that. But to go back to the beginning of the office visit, someone comes in, they've had a PSA done, maybe a little elevated. We talk to them about the rectal exam. We do the rectal exam, and then we talk to them about the MRI, and then we may get an MRI or we may not, depending on how the rectal exam is. And then we may or may not move forward with a biopsy, or if someone's PSA is only slightly elevated, we probably will repeat it before pushing a biopsy on them.
Okay.
So there's a lot of shared decision making that goes on.
Yes. Yeah, because there was one other thing we mentioned this a little bit earlier was the issue of, an enlarged prostate, so prostatic hypertrophy and that kind of thing. And so what is that? And does that mean you're going to necessarily get cancer, or how does that?
No. So as we age, after about age 35 or so, the prostate starts to enlarge as a result of the lifelong exposure to testosterone. About half of the men will have issues with that enlarging prostate, causing symptoms of obstruction or infection in the course of their lifetime. There's no relationship between an enlarged prostate and developing prostate cancer. In fact, most cancers arise in a different section of the prostate than the enlargement area.
Okay.
And so, yes, prostate cancer can cause symptoms of obstruction if it's been there for a while and it's been growing, but that isn't a result of the prostate being enlarged. So patients who have an enlarged prostate, they end up being treated in a whole different way than patients who have prostate cancer. And sometimes the two overlap a little bit.
Yeah, what's the relationship? Because some people are taking supplemental testosterone, sometimes called vitamin T, in the gyms.
Well, we don't really think that the testosterone actually causes the prostate cancer, but in some patients who have a low-grade, non-invasive, clinically insignificant prostate cancer, it can be almost like pouring gasoline on a fire and make it blossom and grow faster. And so we recommend that when patients are on testosterone therapy, particularly after the age of 45 or 50, that they get regular PSAs, regular rectal exams, and that at the first sign of trouble, they be looked at relatively more closely. But no, it doesn't cause the prostate cancer. That's
great. Yeah, and Janita, because this is Janika. This is one of the things, and I'm going to bring you into this discussion now because this is a great explanation that we received from Dr. Cornfield. And as he was saying things, it was sounded like, you're starting to really weave into a network of the required clinical care and social services that sort of fold into this process for you to have a good outcome. So what is your role in this program for the Caregiver Support Program, and how does that fit into things?
Dr. Arnold, thank you. As Dr. Cornfield was talking, one of the things that was going through my mind is something that we promote here at Jesse Brown and hopefully throughout all of the VHA networks, which is inclusive care, right? So when we're talking about where men, primarily Black and brown men, are dealing with, prostate cancer and awareness and things of that nature, a lot of the times we invite family members to come and be inclusive with their care, right? And to really have a seat at the table, to really be involved. I know my husband all the time is talking about, I can't remember what my doctor said. So a lot of the times I have to, step in. And so a lot of the times here at Jesse Brown, that's what we're seeing in our program as well. So here at the Caregiver Support Program here at Jesse Brown, we offer a myriad of clinical and support services for caregivers who are caring for our nation's veterans. This program was curated and developed as a part of the Omnibus Act, where VA realized that we had a lot of people returning home post 9/11 who were really coming back without tools, without resources, who really had critical and traumatic mental health and physical debilitating illnesses, and they needed support. And they realized that family and friends were leaving behind their lives that they knew when their veterans came home, and they realized that there was a critical need to support those people who held those veterans up. And so with that, we started with the post 9/11 caregiver support program, and that pretty much was open to all post 9/11 veterans. And it was under the Missions Act in 2018 that expanded this service to all era veterans. And we did that in 2 phases. Starting in 2020, we opened it up to our prior to May 7th, 1975 veterans. And then phase 2 of October 2022, we opened that up to include all eras of veterans. So yeah, that's pretty much how we got started.
That's fantastic, because the major message I think you're telling me is that you're not alone in this. And I remember when I was first diagnosed with prostate cancer in 2003. It was in October of 2003. I had the surgery in December, and then I was in Iraq March of 2004. and so one of the things that I learned is as a patient, because as a physician, you sit there and then you hear the diagnosis and you completely leave the room. You are not there anymore. And you turn around and go like, what did you just say? I have a diagnosis. So it's good to have people there to help you and help you through it, and to know that there are people there. If it wasn't for people like Dr. Cornfield, I might not be alive today. I had my surgery back in 2003. This is 2024.
Yeah.
And, haven't had no comments. I went in because my father had prostate cancer. And then after that, I told my brother, identical twin brother, and he went and he had it. And so he had the surgery as well. So this is something that it's something that we have to talk about, and you have to know that there are people there that can help you, that can actually save your life and stop you from going through unnecessary pain, suffering, and then your families to go through it with you as well. So it's important to get the care early and to make sure that you are having routine checkups by your personal doctor, just like you have it for anything else, for diabetes checks or high blood pressure checks. So prostate is part of your body, and that you need to take care of it and understand how it functions and how it works in your body. So one of the things that I was warning about is also, is there a way to prevent prostate cancer? Because a lot of people have things out there. They have, everything from eating pumpkin seeds to elixirs and off the shelves. So
there's a lot of supplements out there,
right.
None of which have really been shown to be efficacious in preventing prostate cancer. There is a study going on about concerning finasteride and Avodart, dutasteride, as to whether or not the use of these drugs can prevent the development of the less aggressive disease. But yet that's not going to do much for the more aggressive disease. And in fact, it's the more aggressive disease that we really worry about, because now we know that the cancer it's really more than one disease. It's a spectrum of disease. Well, it's one disease on a spectrum of disease. And the milder forms are ones that we can watch. And the trick is to suss out which ones are actually milder, and which ones are more aggressive, and which ones require care and treatment, and which ones we can wait for a few years before we do anything. The one thing that we do know is that one of the things that can contribute to the development of prostate cancer is high-fat diet and alcohol. Are the two things that we know. So, if you do develop prostate cancer, you may very well be able to slow its course a little bit by changing your diet and giving up drinking. If you're younger and you don't have prostate cancer, then you may be able to stave it off by giving up alcohol and changing your diet. And I don't mean, never have a hot dog, never have fries, right? But don't only have hot dogs and fries.
Yeah.
And then from an incidence standpoint, just to put things in perspective, if you take a man who's 100 years old randomly, and you do a prostate biopsy on him, 100% of those men are going to have prostate cancer. Doesn't matter what race, what religion they are, where they come from, they're all going to have some degree of prostate cancer in their prostate. And so we do know that it's really important to be able to ultimately determine which of these cancers are the ones that are going to affect this host in the course of their lifetime, as opposed to the ones that they can live with and die of something else with.
Yeah, because that's what, one of the things that used to really irritate me was the issue with high blood pressure, when people were being told, just eat garlic, don't worry about taking medication, friends' advice. And that's why I was asking you that question.
It didn't do me any good.
No. So that's one of the things that I worry about, is that people are telling them, well, just eat some pumpkin seeds and don't worry about it. Your doctor said you have to come back, but you can take care of it yourself. And
yeah, I have been told by patients that pumpkin seeds cure, deal with prostate cancer, prostatitis, BPH, bladder symptoms, and kidney stones.
Oh.
Yes.
So everything on the sink.
Everything under the sun.
So one of the things is, how do people get in touch with the advocacy program? The Caregiver Support Program is at Jesse Brown VA, but some of the veterans may not be aware of it, and how to find out more information and to get in touch with the department, the Veterans Affairs Department. The VA, first of all, gives excellent care and excellent service. It's my experience for going there. And it's something that I think people need to know that is an avenue. So if they're sitting there and just are there to get a flu shot and that's all they want to do, maybe they need to do a little bit more looking into themselves and getting an evaluation, having a primary care and a referral, to your urologist, and if necessary to the Caregiver Support Program if something happens and you find something. So how do people get in touch with that, and what's the recommended approach for a veteran who's walking into the VA for the first time?
Is that for me or
yeah, I guess for both,
Well, for us, we usually get our referrals from the primary care service.
Okay, yes.
So usually what will happen is they'll come in, they'll establish care with a primary care doctor, and then the primary care doctor will do the necessary lab work and the necessary exam, and then make a referral to us. Although, if they do want to come in directly, we don't have an issue with that. And if they want to call in and get to the clinic schedulers, they can certainly schedule an appointment.
Yes. Okay. Yeah, and what about your view, Janika, about getting in touch with your support services? You're the manager of the Caregiver Support Program.
Absolutely. So anyone who is interested in support services can reach out online. Our website is www.caregiver.va.gov. We have a facility locator. So even if you're not in the Chicagoland area and you receive care at another VA, you can click on that locator button and come right to us. There's plenty of information about our two programs, Program of Comprehensive Assistance for Family Caregivers, as well as our Program of General Caregiver Support Services. So you can find more information about what fits your needs there. And if you have any questions, you can reach out to us.
Oh, fantastic. Yeah, and one thing I want to really go back and touch on something really quickly. It was the issue about the PSA, because people are confused about the PSA, what the numbers mean, and what does that mean for me? Do I have to get surgery? So maybe you can go through that again. That's a question that always comes up.
Yeah, the PSA has become pretty controversial for an unnecessary reason. Because when it first came out, and this is back in the 80s when I was in training, it was the only marker that we could really use with any accuracy in terms of deciding who should be looked at and who we can maybe leave alone. And that's really still the case. So we use the PSA as a screening tool. It's not a diagnosis of prostate cancer. Someone with an elevated PSA could have that elevated PSA because they have some inflammation or because their prostate is a little bit enlarged. Although it does not go up when you're riding the bike, which is things that we've heard in the lay literature and on television. That's not really true. Although we do tell people, don't ride the bike for a day before you come in. If you're constipated and you have and you strain a lot at the bowel movement, the next day your PSA may be up. If you ejaculate, your PSA may be up for a day or two. So those are things that people should be aware of. But usually when someone comes in, we get a PSA, it's elevated, we will always repeat it. Make sure that it's something that is worth looking at.
Okay.
If it is consistently elevated, then we'll usually move on. And depending on the patient's age and what kind of previous workup they've had, we'll go ahead and get an MRI. And then we'll look at the MRI. And if the MRI has a lesion on it and the PSA is elevated, then we'll ask the patient to undergo a biopsy.
Biopsy, yeah. Okay, so we're out of time before my producer gets angry at me, but we're going to have both of you back again. This was a fantastic conversation and something that I think everyone needs to hear. So stay with us. We'll have another show coming up. But then thank you so much, Dr. Cornfield, and thank you, Ms. Walker. You have really enlightened the people who are listening to this, and
thank you for having me.
Lives, and thank you for your service to the veterans.